Just
Yeah.
Yep.
Perfect. Okay, got it. All right, Tommy. So we got a lot of ground to cover. I saw your questions, and I think we should just kind of go one after the other, right?
Okay.
And you need to know a little. You need to break it down a little bit. And I assume that you're going to make part of this is going to be your journey too, right?
Yes.
And your personal story as well.
Yep.
Now, remember, there's a difference between what you had and what Sadie had.
Yes.
Okay.
Yep.
Very different. In that she is a true blue baby because she didn't have a lot of pulmonary blood flow.
Yep.
Okay, at the very beginning. Your malformation is different because you were blue, but you had too much pulmonary blood flow. You had what is called mixing inside the heart.
Yep.
So that's the difference between truncus arteriosus and what Sadie had, which is double-added right ventricle with pulmonary stenosis. By the way, how's she doing?
Amazing. Great.
Really?
Yeah. She just started.
Everybody loved you guys, here in Chicago. So what's there not to love about the Duffys?
Yeah.
Okay. So talk to me. Okay, let's just start with the first question.
Okay, so the first question was, who were the key medical professionals involved with pioneering the surgery, and how does that relate to what you do now?
So, what I would do is keep this sort of focused on the blue baby,
Yep.
right? Because there's different eras in cardiac surgery that have to do with the different players and what kind of disease that they actually address, right?
Yep.
So if you stick it to the blue babies until 1944, when the first Blalock Taussig shunt was done, and I believe Sadie had a shunt to start with, if I didn't do her repair first. But I do think that she may have not had a shunt, but it tells you a little bit about how you do. So all of these lesions are characterized by having poor pulmonary blood flow. So basically, just the bottom line of these malformations is that there's not enough pulmonary blood flow, right? So if you're blue and you don't have enough blood flow, then people for a long time were thinking, well, what can I do to increase pulmonary blood flow?
Yep.
And so the first, people that you really want to hone on are the people from Hopkins, right? And there's a great, direct connection with you and with Sadie. But most importantly, before 1944, these kids died.
Yep.
Or they survived by, just a miracle, but they were very, very blue. And eventually, the body compensates, but then you're kind of a victim of that compensatory, mechanism. So these kids that were chronically cyanotic, when you're chronically cyanotic, you're blue, you try to compensate. How do you compensate? By increasing your hematocrit, which is the amount of blood cells,
yep.
Right? If you don't have enough oxygen, you just increase that, right? So usually these kids would succumb to the sequelae of too much viscosity in their blood. The blood was just too thick. They would have strokes. They would have, other issues like that. And I see that when I go overseas.
Yep.
Because when you go overseas, blue babies have not had an operation as an infant.
Yep.
They're just left to the natural history of their disease. So back to your question. Before 1944, no one really knew what to do about these kids. And one thing that I would encourage you to see is a movie called Something the Lord Made, which I'm sure you've probably seen, right?
Yep.
Great movie, but it's really the story of the blue baby operation in Hopkins. And it really, tells the story. So I would say that the most important individuals very early on are Alfred Blalock, right? Helen Taussig. And what you need to know, and this is kind of important when you talk about, and you can make this you can really put this in your, presentation, whatever you're going to do. Nowadays, diversity is so crucial to anything we do, right?
Yep.
And inclusion, right? So you have Alfred Blalock, who is the white professor.
Yep.
You have Helen Taussig, who's a dyslexic woman,
yep.
Right? And then you have Vivian Thomas, who's an created this operation basically, and you know the stories. I don't need to go into detail. You tell me if at some point we need to get that more in details in terms of the story of the blue baby operation. But what they ended up doing is doing the first Blaylock Taussig shunt, and the Blaylock Taussig shunt is what we call the closed heart procedure, right? And the closed heart procedure. And I will send you actually some articles that I wrote actually on the history of pediatric heart surgery. So you can just look at these people, get some images and pictures, even though everything is on the internet now. And the closed heart procedures imply that we're doing an operation without stopping the heart, without entering the heart.
Yep.
We're doing something around it to jerry-rig things so that you solve the initial problem. So in a patient like Sadie, if she was a newborn with a lot of problems with not enough pulmonary blood flow, we would do a Blaylock Taussig shunt. So I would say that these are the three individuals that really ushered the era of closed heart operations that just started in the late 30s. Okay, so that is what you want to know. These are the three people, going to your question, who I think were instrumental ushering a new era where kids could be treated with heart disease. And then, a lot of these kids just were left in that condition for years.
Yep.
Because there was no availability to open the heart, right?
Was that just
fix the problem?
Was that just because people were too scared to go in and it was seen as
Well, so first of all, remember that only 50 years earlier, at the end of the 1800s, a very important physician his name was Bierroth. And Theodor Bierroth was a professor of surgery in Vienna, in Austria, just publicly stated that those who actually think about operating on the human heart should lose the respect of their colleagues. It was so bad, okay? So, so part of it was that people were afraid of doing it. Part of it was that there was no technology to do that.
Yeah.
Okay. So then what happens? Is the history evolves to the era of the early open heart operations. Okay. So at the beginning, closed heart operations, the blue baby to fix, the problem, but it's a palliation. Remember, there's two things: palliation and correction. Palliation means I'm just going to jerry-rig things around so you're not blue anymore.
Yep.
Okay. And actually, if I can find it, I have a great video for you of one of the early babies that had this operation. It's a fantastic video. If I can find it, it'd be great. And write this down so you'll remind me of something. So then everybody came to Baltimore. Thousands of kids. Remember, before 1944, Helen Taussig, who was the head of pediatric cardiology, she just saw these kids and just watched them die and would hear them, even though she was completely deaf. She had a special stethoscope. And so imagine how much she had to overcome. And she actually had a practice where she will be in the morgue with these kids who will be dead. And on the wards with these kids, she couldn't do anything about, right? So here comes 1944, and right when we were going to Normandy, because that was the year, only a few months before, they started doing these operations. So a lot of kids from all over the country came about and got their blue baby operation. Now, fast forward about 10 years, 1953-54 is the era of the very first open heart surgeries. And most of these surgeries occurred in one of two places: University of Minnesota and Mayo Clinic. All right.
Yep.
But so the first time that somebody ever fixed somebody's heart inside was in 1952, I think. His name was John Lewis. And John, the chapter I'm going to send you, I have a picture of him and I have a picture of the first operation when somebody was staring into somebody's heart inside. And he just kind of closed off the inflow into the heart, closed off the outflow. And as quickly as he could, he shut off a hole between the upper heart chambers, which you had to, Sadie had to. Okay?
Yep. Oh,
But this was not good enough. So right afterwards, there's a guy that you want to learn about. His name is Walter Lillehei. Walter Lillehei was a really maverick, daring cardiac surgeon at the University of Minnesota. And what he did is he devised the first open heart surgeries by having mom or dad on one side and the patient on the other. So the mom or the dad would function as the heart-lung machine. You see what I mean? And then with the heart beating and bleeding out, he would open the heart, and as quick as he could, he would repair a defect. So he started repairing ventricular septal defects like you had, like Sadie. He started opening, closing holes. He started doing these operations, okay? And then to follow, for the blue babies, there was also something called the open pulmonary valvotomy, where somebody would just blast open the pulmonary valve to have more blood flowing to the lungs. But in any case, these guys started doing this, what is called cross circulation, which was the only operation, jokingly, that people would say could have a 200% mortality. Because mom and dad could both die. I mean, mom and the son could both die, right?
Yep.
Crazy. There's some great pictures in the book. And then the first correction. Now, at this point, you can't always have the mom do this. They, at this time, they could actually do this with 50% mortality, which is like huge.
Yeah.
In this day and age, I would go to jail if I had a 50% mortality. Back then, if you didn't do anything, it was 100%.
Yep.
Right? So they were heroes regardless, right? So fast forward a couple of years, people started thinking, there's got to be a better way. I got to have a machine that allows for me to fix this heart, and so the person that actually started this was a guy in Philadelphia. His name was John Gibbon. And John Gibbon was married to a woman, and the two of them got together to create the first heart-lung machine.
Yep.
With which they were able to close the heart inside. To close a hole between the upper heart chambers in the heart of a young baby, like 15 or 16 years of age. You got to remember that this guy, this case, it was a success, right?
Yep.
It was not the first heart surgery, but it was the first time that somebody used a heart-lung machine that looked like a kitchen stove.
Yep.
Right now, it looks like a little space machine, right? Here we go. We go to the operating room. He fixes the heart of this patient, and he does 4 cases to follow, and all 4 patients die. And he stops doing heart surgery. But he did the first one. So then, from then on, the issue is doing this with the heart-lung machine. And this was developed at Mayo Clinic by a guy named John Kirkland. Okay?
Yep.
John Kirkland. So John Kirkland did the first double outer right ventricle repair, like Sadie. And I don't know if Walter Lillehei, you should check this, did the first correction of tetralogy of Fallot as well. Or was this done by John Kirkland as the first? So typically in this era, what you have is you have patients who were operated. First of all, the diagnostics were not great, right?
Yeah.
The diagnosis a lot of times would be made in the operating room. That a cap didn't have echocardiography, right? In this day and age, a kid like you or a kid like Sadie, we would just go to the operating room just based on the echocardiogram.
Yep.
Back then, there was no echocardiogram. So they would listen to the heart. The kid was blue. let's do something. Okay. And tops, they would do a calf, which you've had before too, right?
Yep.
Several times. So now we have, now what we do is we have the early open heart surgery era, which lasts until the 1970s. And typically, kids at this age will be shunted first. They would get the classic blue baby operation.
Yep.
And then eventually they will be repaired when they were bigger.
Yep.
So I have a lot of and these were very rudimentary heart lung machines, and people will bleed like crazy. And so what happened there is that in those days, I have a ton of patients who come to me for like a pulmonary valve replacement, right? Later on, they're like 40. And what they had was initially pleotoxic shunt.
Yep.
And then they had a complete correction that typically lasted 10 hours and they almost died. Typical.
Yeah.
Whereas nowadays, we do an operation for tetralogy of Fallot, the baby's back in the unit in 3 hours.
Yep.
Right. And so I do think that that's the next step. So it's early, complete repair. And this happened in the 1980s, where two people did this. Okay. One guy is his name is Sir Barrett Boyce. And you'll see all of these names and stuff in the chapter I'm going to send to you today. Okay.
Okay.
Sir Barrett Boyce was a guy who pioneered what is called hypothermia, which means that it's like you drop somebody in the lake. And I did this for both you and Sadie at the beginning. You just, not as much for Sadie, but I'm sure for you, where you just go to 20 degrees centigrade, you stop circulation to the brain for a limited amount of time.
Yep.
And then you go ahead. In your case, it was not required, but clearly I'm sure we went pretty cold. And hypothermia protects the brain, protects the heart. Okay. So these guys were pioneering hypothermia. They were still doing, and what happens is when the baby's cold, there's not a lot of blood. You can repair everything with no circulation. And they didn't have what is called cardioplegia, which is the solution that we use nowadays to stop the heart. So these hearts would be just quivering at a very low rate. And these were very fast, very good surgeons, right? So one guy is this guy, Barrett Boyce. The other guy is very important. His name is Aldo Castaneda. And he's a guy that really pioneered early complete repair in children. So as you move away from this era, you go into the 1990s and 2000s, where it was all about complete repair of children. And when I trained, we now are in the era of complete repair early. So a blue baby this day and age very, very rarely will have a shunt.
Yep.
Okay. We may stent the BDA, we may stent the right ventricular tract, but I've done complete correction of neonates that are blue, like tetralogy of Fallot, as newborns. They have to have favorable anatomy, and they can be a little bit sicker after surgery, but it's done.
Yep.
And I can tell you that the vast majority of kids I've corrected completely. So these are the names that you need to know in the progression of the approach to the blue baby operation. So that's question number one.
So I found your interview with the 5th or 6th or 7th baby who had the operation at Hopkins.
Wow.
Your video, it's on YouTube. So do you think that his post-op life is significantly different, the amount of surgeries that he had to have? Because he just passed away recently at 80 or 90.
That's right. His name is Mr. Shermer.
Yep.
I remember him. He was a guy that used to make magic.
He was a magic guy. Yep.
Charming guy. And he's one of those kids that had, a late correction. Eventually, Dr. Cameron, who I think helped you in your case, first case, he was actually, he did his pulmonary valve replacement. But I do not think that Mr. Shermer had an operation between his correction and his and it's pulmonary valve replacement. So 56 years went by, and this is a very important thing because I do have patients that I operated on a lady that had this story. She's 70 years old. 70 years old. And I just did her operation and she's fine. But a lot of times older patients, when they get, neglected, if you will, for a long period of time, when they come to surgery, their hearts are very big.
Yep.
They're very dysfunctional. So in your case, there's now a focus of our community to have no obstruction to blood flow and not a lot of regurgitation on the pulmonary. It's all about the right ventricular outflow tract, as it is for you and for Sadie and for all the blue babies, because the hole between the lower heart chambers is fixed, right?
Yep.
In your case, you also have to worry about the truncal valve, but you're doing pretty well. So the patients that went through the surgery early on, they were never the patients that would be playing water polo.
Yeah.
See what I mean?
Yep.
But Mr. Shermer had a very, very fulfilling and productive life.
Yeah.
And I think he was number 7 or whatever, but the 3 kids before him and the 5 after him died.
Yep.
Something like that. So imagine what kind of, paradoxically, the pressure that surgeons had back then was in many ways, in my mind, a little bit less of the pressure that surgeons have now. Because when I go and do a repair right now, I have to have a good result.
Yep.
Mortality in a tetralogy of Fallot and complete repair is almost 0.
Yep.
Back then, the kid died. Well, you know what? So did the 5 kids before me.
Yep.
Right? Very different.
What was shocking to me when I watched your interview was that he lasted so long without any external, like he was an old man with with the same thing that they did in the 40s, and he hadn't had any.
Absolutely. And I always take this to my pediatric cardiologist and say, you know what, we all so obsessed about putting a new valve and whatever. We have patients who are in their 60s now, the original blue babies, and have gone through their entire lives. Now, there's a risk of arrhythmias. There's a risk of sudden death. So if you leave these hearts unattended, but you can make it to adulthood and clearly also in the elderly age with not a lot of operations, right? When did we do your last operation?
I haven't had an open heart since I was like 3, 2, 3, 4.
No. So no, Tommy, you've had your heart surgery, I think, when you were like 5 or 6. We did replace your conduit.
Yes.
Yeah.
I had
go ahead.
I had what's the word that I'm looking for? The blocking of the valve.
Yeah.
And then it filled and endocarditis. And I had that when I was 12 or 13. And so that was 5 years ago.
That's right.
4 years ago.
But you've not had surgery for a little while then.
No.
And who's your cardiologist?
So Dr. Murphy just retired 3 months ago.
Yeah, I know.
So now it's Dr. Doshi.
Doshi, okay. Well, you make sure that she lets me know how you're doing, okay?
I will.
We have a very strong connection with your family, so I want to really make sure that things are good. All right. So what else? Next question.
So you answered like 5 of them off the bat. Heart and lung machine you covered. What advancements are you hopeful for in the future as we get more in the new era?
That's a good question. Yeah, so I think the advancement in the future, so for the blue babies, and we're just for simplicity, we're going to talk about blue babies that have problems with the outflow tract, right? And in a way, you're a blue baby that now your next thing is the outflow tract, right? You have a conduit there, right? And Sadie has a valve. And so for the blue babies in particular, the nature of the game long-term is the holy grail of cardiac surgery for the last 50 years, which is having a valve that is competent, that has got longevity, that doesn't get obstructed, and doesn't leak. and ideally can be deployed without heart surgery. So that is, the holy grail. We've never really gotten to that. And my hope is that in the next 10 years, we will develop a technology based on stem cells where for these children, I will be able to take your stem cells, grow and 3D print a conduit with a valve in the lab, and the so ask me about the future of cardiac surgery and cardiology research as it pertains to the blue baby in particular. That's where I hope it's going to be. Because let's face it, your ventricular septal defect is closed, your truncal valve works well, and your right ventricle is your future.
Yep.
And it's the same thing for Sadie, right? It's a valve. So if I say for you or her that I can go through the groin and just deploy a valve, build in the lab with your own cells, that would be great. Nobel Prize right there.
You covered all those right in that one question. Honestly, the last one, looking back on your career, what are you most proud of in general? And you can be in as general as what.
Sure. What am I? So I'm not proud. I mean, you ask me what I'm proud about. It's not the difficulty of the operations. It's not how many transplants we've done. It's not how small is the smallest baby I've ever operated on. I think what I'm most proud of is to have been able in my life to help patients that are children and help their families. It's like, with what we do, we help, a child that is going to be, an adult, that is going to have kids, that is going to do well in school. So to me, my greatest pride is see kids like you who are doing great in life. They were dealt with, kind of a, not a great hand at the beginning, but because of that initial, struggle and doing what we can, with surgery, you're now a thriving, young man. And it's the same thing with Sadie. And at the same time, we touch the lives of a lot of people. So that's one thing we're proud of. And the other thing those of us who are in academics we're proud of training the next generation of surgeons. So it becomes almost a gift that keeps on giving.
Yep.
Yeah.
So you're actively teaching? Like, is that are you?
So, so for me, I've been, trained at quintessential training institutions. And I have, at Hopkins, I trained a lot of physicians. Right now, my training, is different. We don't have a lot of trainees that do specifically pediatric heart surgery. So, I have, how can I say, we're training the next generation of surgeons. A lot of them will not go into pediatric heart surgery.
Yep.
Because they will go into adult cardiac surgery or whatever. So I'm more involved in operating right now than actually teaching fellows and residents as opposed to when I was at Hopkins. But they still have the residents and fellows that come through the service, and it's always a pleasure for me to just train the next generation.
Yep. I think that you covered all the bases. Thank you so much for your.
Sure. So Tommy, this is the thing I wanted to also tell you.
Yep.
First of all, I will send you a little bit of material that you can just kind of browse and look at. And, I'm going to send you a chapter that is in the making right now by a colleague of mine, and a chapter that I wrote about the history of cardiac surgery and the blue babies. Then, if I can find this video of one of these first blue babies, I'm going to send it to you. Okay. The other thing that I want to tell you is you're always welcome to my operating room. Okay. So we have a lot of high school students, college students that just want to visit for a day. You want to come over, we will find a day where we're doing a blue baby operation and you can stay right behind my shoulder the whole time. Okay.
Okay.
So the invitation is there. We can work it out in any way, and I'll be happy to host you.
Thank you.
All right. All right,
Awesome.
Tommy. So keep in touch. Let me know how I can help you. Please give a hug to your family for me.
I will.
Okay. To Sadie in particular. Okay. Terrific. All right. So long. So tell hi to your parents. Okay.
Thank you. Bye-bye.
Very good. Nice talking to you. Okay. You take care. Good luck with the project. I look forward to seeing it.
I will definitely send it to you.
Terrific. Take care, Tommy. Okay. Bye bye.
Yeah. Bye.